Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Kawasaki disease, part of our vasculitis series of episodes. So what is Kawasaki disease? This is a medium vessel vasculitis, as you'll recall from the Chapel Hill classification, which we put up in the first episode of this series. It is characterised by an acute febrile illness with systemic vasculitis of unknown cause. This disease is most common in children under the age of 5, with a peak onset of 1.5 years. It tends to be more common and more severe in males. There are several signs and symptoms which are very classic of this condition. Firstly, children do tend to have a fever and they have a rash, particularly affecting their palms and the soles of their feet. They will have red, cracked lips and a strawberry tongue on examination. They often have conjunctivitis as well as angina and cervical lymphadenopathy. Investigations should be led really by the fact that the patient usually presents in extremis, very unwell. Your top differential diagnosis would probably include an infection, so it's really important to do all of the usual tests you do if you were trying to rule out a severe infection in a child. But some pertinent tests for Kawasaki disease in particular are blood pressure, just because of the effect that this can have on the cardiovascular system, a urine dip, and blood tests which often show a raised ESR, CRP and platelet count. An echocardiogram is usually performed, but normal findings do not rule out a diagnosis of Kawasaki disease. This condition is treated with intravenous immunoglobulins, or IVIG for short, as well as aspirin. And the treatment is guided by a combination of the multidisciplinary team. So this may include, or should include rather, a paediatrician and specifically a paediatric cardiologist, paediatric rheumatologist, and sometimes intensive care may also be involved. So just going on to some questions about this condition. Which of the following is not a typical feature seen in Kawasaki disease? Erythematous rash to the extremities, strawberry tongue, cracked lips, proximal arthralgia, and cervical lymphadenopathy. Now, the question is asking which of these is not typical. So as we've seen, options 1, 2, and 3, and 5 are classic features of Kawasaki disease. And while the patient may be in pain in their joints included, proximal arthralgia is not a typical or classic feature of Kawasaki disease, and therefore the correct answer is number 4. A 20-year-old lady brings her 1-year-old son into hospital after noting a temperature of 40 degrees Celsius at home. This is confirmed in the emergency department. The child is found to have a strawberry tongue and cracked lips on inspection. Which of the following is not a required investigation for this patient? So if you just think about how the patient has presented and what we would be suspecting, you're really suspecting that A, the patient is septic, or B, that they've got Kawasaki disease, and then there are more rarer differential diagnoses. So the options are blood cultures, chest x-ray, echocardiogram, bloods including a CRP and ESR, and a lumbar puncture. Now again, all of these may be done at some stage, depending on how the differential diagnosis progresses. But given that your top differential in this situation should be Kawasaki disease or potentially sepsis, the lumbar puncture is not the essential investigation here, but all of the others would be. So thank you for listening to this episode of Bite-Sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you'd like to hear from us in the future, and we'll see you in our next episode.